Equipment Lesson 20 covers pathology and technique adjustments, an advanced lesson and one of the most clinically applicable topics on the ARRT. Pathology changes tissue density. Technique must compensate. Every patient you image may have a condition that requires you to deviate from the standard technique chart. This lesson covers additive versus destructive pathology, cast and foreign material adjustments, body habitus, special populations, and contrast media considerations. 14 minutes. The core concept: pathology changes tissue density, and technique must compensate. 2 categories. Additive pathologies increase tissue density, require more MAS. Destructive pathologies decrease tissue density, require less MAS. Additive pathologies, conditions that add to tissue attenuation. Ascites, peritoneal fluid accumulation. Pneumonia, alveolar consolidation. Pleural effusion, fluid in the pleural space. Atelectasis, collapsed lung tissue. Paget's disease, increased bone density. Edema, fluid in soft tissues. Cardiomegaly, cirrhosis. All of these increase attenuation. The standard technique underexposes. Destructive pathologies, conditions that reduce attenuation. Emphysema, air replaces alveolar tissue. Pneumothorax, bowel obstruction with gas distension. Cachexia, osteoporosis, decreased bone mineral density. Multiple myeloma, osteolytic metastases. All of these reduce attenuation. The standard technique overexposes. The memory rule: additive pathology adds to attenuation, add MAS. Destructive pathology destroys tissue, reduce MAS. The bar chart on this slide shows approximate MAS increases required for common additive conditions. These are approximate values. AC systems compensate automatically, but the radiographer must understand why the technique changes. Mild ascites, approximately 30% MAS increase. Severe ascites, 80% or more. This is the most commonly tested additive pathology on the ARRT. Pneumonia, approximately 25%. Pleural effusion, approximately 35%. Paget's disease, 30 to 50%. AC systems generally compensate automatically for these changes. The MAS increases to reach the target exposure. For manual technique, deliberate increase is required. For AC, verify the resulting MAS is within the expected range for the pathology. 6 material types with specific technique implications. Wet plaster cast, highly attenuating. Increase MAS approximately 50% above dry cast technique. Wet plaster is significantly denser than dry plaster. Orthopedic teams generally prefer imaging after the cast has dried when possible. Dry plaster cast, moderately attenuating. Increase MAS approximately 25 to 30% above uncast technique. Some facilities maintain dedicated cast technique charts. Fiberglass cast, lower density than plaster. Approximately 15 to 20% MAS increase. More radiolucent. Underlying bony detail, generally better visible. Splints and braces. Air splints require minimal adjustment. Metal braces require significant increase and will produce beam hardening artifacts. Remove removable metal hardware before imaging whenever clinically possible. Contrast media in field. High-density iodinated contrast can cause AC underexposure. The dense vessels trigger early termination. Vérifie technique. Barium in the GI tract requires higher kVp for adequate penetration. And dressings. Standard gauze dressings require no technique change. Bulky bandages may require minor increase. 4 body habitus classifications. The ARRT tests these directly and assign specific technique implications to each. Sthenic, average build. Standard technique charts are calibrated for the Sthenic habitus. Organs in average position. Approximately 50% of patients. Hypersthenic, broad, massive build, significantly increased tissue thickness. Liver and gallbladder positioned laterally and high. Colon more lateral. Increase MAS substantially. often 40 to 60% or more above standard. Approximately 5% of patients. Hyposthenic, slightly below average. Minor technique reduction needed. Organs slightly lower and more medial than sthenic. Approximately 35% of patients. Asthenic, very slight, almost frail build, significantly reduced technique. Organs positioned low and medial. Major MES reduction from standard technique. Approximately 10% of patients. The registry tests organ position by habitus as well as technique. Hypersthenic, organs high and lateral. Asthenic, organs low and medial. Pediatric technique. Use pediatric-specific technique charts. Never adult charts, scale by weight. Increase KVP and reduce MES relative to adult values to reduce dose. AEC minimum response time is a risk for very small patients. Manual technique may be safer. Short exposure time is mandatory. Motion is the most common cause of pediatric repeats. Image gently. Reduce, shield, speed, limit, justify. Geriatric technique. Osteoporosis is common in elderly patients. Decreased bone density is a destructive pattern requiring reduced MAS. Allow extra positioning time for mobility limitations. Fragile skin and tissues. Minimize compression. Communication. Face the patient, speak clearly, check for hearing aids. Fall risk management. Never leave unattended on the table. The critical note. Elderly patients often have simultaneous additive and destructive pathologies. Chronic obstructive pulmonary disease, a destructive condition, often coexists with pleural effusion, an additive condition. The net technique effect depends on which pathology dominates the anatomy being imaged. Iodinated IV contrast increases soft tissue attenuation in enhanced vascular regions. The AEC may underexpose because dense iodine-filled vessels trigger early termination. Verify technique is within expected range. Allergic reaction risk requires pre-administration screening. Metformin must be held 48 hours post-contrast in patients with renal impairment. Oral barium contrast. Very high density in the GI tract. Upper GI technique requires higher KVP for adequate penetration through barium. Double contrast studies combine barium, coating the mucosa with air, distending the lumen. Technique must account for both extremes of density within the same field. Negative contrast, air or carbon dioxide. Reduced attenuation compared to surrounding tissue. Less technique needed than positive contrast. Used in double contrast studies for maximum mucosal detail. Never use barium if perforation is suspected. Barium in the peritoneal cavity or lungs is catastrophic. 7 pathologies the ARRT directly tests. Ascites. Increase MES 50 to 100%. Peritoneal fluid dramatically increases abdominal thickness and attenuation. Most tested additive. Pneumonia. Increase MES 25 to 35%. Alveolar consolidation replaces air with dense fluid. Emphysema. Decrease MES 25 to 35%. Air replaces tissue. Drastically reduced lung density. Most common destructive pulmonary pathology. Osteoporosis. Decrease MES 20 to 30%. Reduced bone mineral density. Common in elderly female patients. Wet plaster cast. Increase MES approximately 50%. Paget's disease. Increase MES 30 to 50%. Bowel obstruction. Decrease MES 25 to 30%. Gas-filled, distended bowel attenuates less than normal. 3 pathology and technique questions. The answer is B. Increase MAS to 75 to 100. Ascites adds peritoneal fluid that significantly increases beam attenuation beyond what the centimeter measurement alone predicts. Technique charts are calibrated for normal tissue density. Ascites adds abnormally dense fluid on top of that. Even the 28 centimeter measurement doesn't fully account for the degree of increased attenuation. Manual technique requires a deliberate 50 to 100% increase for severe ascites. The answer is C. Decrease MES 25 to 35%. Emphysema is a destructive pathology. Air replaces and destroys alveolar tissue, dramatically reducing lung density. Air attenuates the X-ray beam far less than soft tissue. Standard chest technique overexposes the lung fields, making them appear too dark and washing out vascular detail. Reducing MES compensates for the reduced attenuation. This is one of the most clinically common destructive pathologies on the ARRT registry. The answer is C. Increase MES significantly. The hyperesthenic body habitus is broad and massive, significantly more tissue thickness than the asthenic patient for whom technique charts are calibrated. Greater tissue thickness means more beam attenuation and more scatter. MES must be increased substantially, often 40 to 60% above standard, to achieve adequate penetration. Body habitus is a directly tested technique concept. You covered additive versus destructive pathology with examples of each category. The technique adjustment chart for additive conditions, casts and foreign material technique effects, the 4 body habitus classifications with technique implications, pediatric and geriatric special considerations, contrast media effects, and the complete pathology adjustment summary table. When standard technique is insufficient. This lesson tells you why and what to do about it.